You want me to tell you a secret? Well, grab your piece of paper and hello and welcome to MK's Exam Secrets Season 2, Episode 3. Today we're going to be covering obstetrics and gynecology again because someone requested for it on the comment section on the community. My name is Dr. Moses Kazevu. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. So let's dive into this. So beginning with our question 1, and you already know the drill, you may pause the video at any point to answer the question. So beginning with our question 1, vaginal and cesarean deliveries are two known methods or two known modes of childbirth. Each of these methods has advantages over the other. Describe the advantages or benefits to the mother for each of the methods. You may pause the video, and here comes the answer. So remember that the advantages, so how you can answer this question and tackle this question. Remember that they're telling you that you have to describe. A description is just not just merely stating something, okay? But you just have to pretty much explain in a bit more details. So the advantages of a cesarean section over vaginal delivery, these include things like lower risk of incontinence. Remember that with vaginal delivery, there's a high risk of pelvic organ prolapse afterwards. There's a high risk of urogenital dysfunction and urogenital incontinence. And also there is a lower risk of sexual dysfunction after the birth of the child. That's the first most important thing of an advantage of cesarean section versus vaginal delivery. The second thing is that there is a lower risk of the child being deprived of oxygen, although this could translate to the process of a C-section being shorter than the normal vaginal delivery, which is the advantage to the mother. Because remember, the question is asking us the advantages to the mother. So it's much shorter process for the mother to be in this process because the cesarean section doesn't take so long as compared to labor, which may take a much longer period if you're comparing both normal processes being done competently. Then, of course, the third risk is that there's a lower risk of the child experiencing trauma while passing through the birth canal. So there's reduced birth injuries. Of course, this may have a psychological toll on the mother if the mother to the infant realizes that her child is injured. Then, of course, cesarean sections may actually be scheduled in advance, and this makes them actually more convenient and predictable than vaginal delivery and birth, which can actually happen at any time. It didn't happen before the planned date, or it can even happen on the planned date or after the planned date. But with the C-section, you always plan and say that this is what we're going to do on this particular day. Then, of course, those are advantages of cesarean sections. Now, advantages of vaginal deliveries as compared to cesarean sections. Remember, there is a shorter hospital stay for most women that carry out a normal vaginal delivery, and the recovery times are much quicker as compared to those that have C-sections. So typically with someone who has a vaginal delivery, they may stay in the hospital for a day or even 2 days, although it may be shorter depending on the laws of the state and the laws of the country. Then, of course, there is a less risk of surgically associated complications to the mother when you do a vaginal delivery as compared to a C-section. So things like severe bleeding, scarring, infections, reactions to anesthesia, and even longer lasting pain with cesarean section. We don't usually see that with vaginal delivery. Then, of course, the process also has been linked to enhance milk letdown, because remember that parturition is mainly enhanced by oxytocin. And oxytocin not only functions to cause contraction of the uterus, but it also stimulates the myoepithelial cells to contract in the breast and to help with milk letdown. And also this provides a good psychological connection between the mother and the child. Then, of course, during a vaginal delivery, the muscles involved in the process are more likely to squeeze the fluid in the newborn's lungs, reducing the incidence of breathing problems, and also having that good psychological effect that on the mother that the child is well. So this is just some of the advantages of C-sections as compared to vaginal deliveries. Then moving on to question 2. Preeclampsia is a multisystemic disorder affecting pregnant women, commonly manifesting at mid-pregnancy and responsible for maternal and fetal morbidity and mortality. Define preeclampsia, describe the etiology of the disease, what are the possible hematological changes associated with severe preeclampsia, outline management and fetal complications associated with neglected or untreated severe preeclampsia. You may pause the video right now to scream the answers at your screen. And here comes the answer. So remember that preeclampsia is just simply a sustained or a persistently sustained high blood pressure in pregnancy, and you give values of greater than 140 over 90 millimeters of mercury recorded at least 2 occasions that are 4 to 6 hours apart, in the presence of at least 300 milligrams of protein in 24-hour urine, and arising after 20 weeks of gestation in an individual that has not had pre-existing hypertension. That's the definition of preeclampsia. You should remember all these things in your answer. Now describe the etiology of the disease. So remember that the exact mechanism as to how preeclampsia comes about is not well understood. But what we actually know is that with preeclampsia, there is a problem with the infiltration of the cytotrophoblastic cells into the spiral arteries beyond the decidual myometrial junction. So you remember that this happens during the second wave of invasion. There are 2 waves of invasion that usually happen. And the first wave happens much earlier. The second wave happens roughly around 16 to 18 weeks. Then, of course, this also is supposed to be coupled with remodeling of the spiral arteries where they become less resistance. So it means that there is increase in diameter, increase in tortuosity of these arteries. And then, of course, this is meant to bring a lot of oxygen, a lot of blood supply to the placenta. But this doesn't happen, and the placenta does not get a good oxygen supply. So this means that as the pregnancy advances, the oxygen demands also increases. There's a shortage in this. And of course, this results in ischemia and produces a lot of these chemical mediators of inflammation, such as thromboxane A2, as well as other mediators or vasodilators like prostaglandin E2 and nitric oxide are going to be decreased in amount, and then increase in vasoconstrictors. Angiotensin 2 is a very important player, thromboxane A2 and endothelin that are flushed into the mother's system, and of course these are the ones that are going to be bringing about the characteristic signs and symptoms that we see in preeclampsia. Then, of course, there are some risk factors that have been associated with preeclampsia. Of course, this question is not really asking us about risk factors, it's asking us about etiology, which is the cause. Then, of course, what are the possible hematological changes associated with severe preeclampsia? Remember your so-called HELP syndrome, your hemolysis, which may be manifested as schistocytes and Helminth cells. These are just pretty much fragmented red blood cells. Then, of course, you may have a low HB, but in some cases, you may have an elevated HB and a hematocrit that's elevated due to the hemoconcentration that we see in preeclampsia. Then, of course, you may have a low platelets because this is part of HELP syndrome. Then, of course, outline maternal and fetal complications associated with neglected or untreated severe preeclampsia. Remember that complications can be to the mother, or complications can be to the fetus. In the mother, the complications can be prenatal, intrapartum, postpartum. Then, of course, fetal complications can also be prenatal, intrapartum, and postpartum complications are not so significant on the child unless if it's maybe a preterm labor where the child is going to be premature with the complications of prematurity. Then, of course, the maternal prenatal complications, number 1, you could progress to eclampsia. This can happen before labor, it can happen during labor, it can happen after labor where the mother progresses to eclampsia. The mother could develop cerebral hemorrhage, they could have a liver hematoma and hepatic rupture, they could have placental rupture. Then intrapartum complications, like I said, progression to eclampsia, postpartum hemorrhage, which is often attributed to coagulation failure. Then postpartum, the mother could have shock, sepsis, and eclampsia. Then fetal complications include intrauterine growth restriction, which is due to chronic placental insufficiency, intrauterine fetal death, and even prematurity due to preterm labor and induction, of course, with the associated complications of prematurity. Moving on to question number 3, define induction of labor and list the indications and contraindications. You may pause the video. Remember, in this series, we do 3 questions in obstetrics and 3 questions in gyne. Those were obstetric questions, and then the gyne questions will be coming subsequently after this question. So here comes the answer. Remember that induction of labor is just simply the initiation of regular uterine contractions after the period of viability by any of the methods, medically, surgically, or even a combined medical surgical procedure for the purpose of vaginal delivery. Some indications include women that have postpartum pregnancies, women with fetal distress, or their infants are in fetal distress, then severe preeclampsia or eclampsia, premature rupture of membranes, stillbirths, chorioamnionitis, polyhydramnios, oligohydramnios. But remember that with oligohydramnios with intrauterine growth restriction, it may actually be an indication for cesarean section as opposed to vaginal delivery. Then, of course, contraindications include cephalopelvic disproportion, the so-called CPD, vasa previa, prematurity, major placenta previa or cord prolapse, transverse lie, previous uterine rupture, a previous classical or vertical C-section. Remember now the C-sections that we do are known as lower segment C-section, and they're usually a horizontal incision as opposed to cutting through the uterus vertically. Then, of course, active genital herpes. These are just some of the few contraindications and indications that we have of induction of labor. Of course, there are many that you can remember. Then, of course, moving on to question 4, which is a similar question to what we covered in the previous episode. Cervical cancer is the most common gynecological cancer in Zambia. It can be prevented by screening women and treatment of precancerous lesions. A 50-year-old patient has been diagnosed with cervical cancer stage 2B. She has never screened for cervical cancer in the past. A. List 3 common methods of cervical cancer screening. B. Describe the pelvic examination findings in a patient with stage 3B cancer. C. Mention 2 of the most oncogenic human papillomaviruses responsible for cervical cancer. D. List 2 human papillomaviruses implicated in genital warts. E. How is this stage of cervical cancer treated? And here comes the answer. So 3 common methods for screening for cervical cancer include a pap smear. Remember that the pap smear is one of the most tests that have been developed for the purpose of screening that has been very successful. You can do a conventional pap smear, which isn't so good, high yield, and of course the cells that are going to be there on the slide, it's going to be difficult to read them, but it's very easy to do. Then, of course, a liquid-based pap smear, which requires some expertise, but then of course it's very easy to read these liquid-based type of pap smears. You can do a VIA, which is visual inspection with acetic acid, which is pretty much vinegar, plus or minus a colonoscopic examination with or without a biopsy. Then of course you may perform an HPV testing. You may also do a Schiller's test, which uses iodine or Lugos solution. Then, of course, describe the pelvic findings in a patient with stage 3B cervical cancer. Of course, the growth is going to be spreading to the lower 1/3 of the vagina or the parametrium as far as the lateral pelvic wall. So it means that the tumor can actually be felt in the lower 1/3 of the vagina and the pelvic floor. Then, of course, in stage 3B, there is going to be extension to the pelvic sidewall. There may be hydronephrosis or a non-functioning kidney. Then, of course, mention 2 of the most oncogenic human papillomaviruses responsible for cervical cancer. So you have HPV-16 and HPV-18. Then, of course, 2 that cause genital warts is HPV-6 and 11, which is why when we vaccinate women against human papillomavirus, we give them a quadrivalent vaccine, which covers against 6, 11, 16, and 18. Then, of course, how is the stage of cervical cancer treated? I'm assuming that we are treating stage 3B. Then, of course, if it's stage 3B, it's chemoradiotherapy. So chemotherapy with, for example, cisplatin as a drug and radiation. Then moving on to the question number 5. A 16-year-old patient from a rural area presents 8 days after a vaginal delivery with a complaint of fever of 38.6 degrees. She had a prolonged second stage of 12 hours and delivered her baby by vacuum with an episiotomy. What is the most likely diagnosis? What are the 4 likely risk factors of this condition in this patient? List 4 common complications of this condition. What 4 structures are cut in an episiotomy? How will the patient be managed? You may pause the video at any point, and here comes the answer. So remember that anyone that has a fever that's greater than 38 degrees in roughly about the first 10 days of after pregnancy, then you do refer to this as postpartum fever or puerperopyrexia. Now, the focus here could be most likely from the genitourinary tract, or even could be an infection of the episiotomy wound. So we are not really so sure. And of course, what are the 4 likely risk factors of the condition in this patient? So number 1, remember that this patient gave birth in the rural area. So already that points you towards a low socioeconomic status. Then of course, there may be a prolonged second stage of labor, which she had. The surgical wound itself, the episiotomy, is a risk factor. And of course, the use of vacuum delivery, instrumental delivery, is a risk factor. Then of course, the age of an individual, she's quite young, 16 years old. Then of course, list 4 common complications of this condition. It could complicate into septicemia that can result in endotoxic shock. You could have pulmonary embolism, disseminated intravascular coagulation, pneumonias, abscess formation, and even in the long run, infertility. Then of course, what 4 structures are cut in an episiotomy? The vaginal epithelium, the transverse perineal muscle, the bulbocavernosus muscle, and the perineal skin. Of course, this is in a mediolateral kind of episiotomy. Then how will the patient be managed? So we want to admit the patient, adequate fluid hydration or adequate fluid management, cardiac monitoring, you monitor your vitals, administer oxygen, give this person broad spectrum antibiotics until 48 hours of pyrexia and until there is resolved pelvic pain, if there is any pelvic pain. Then moving on to our last question. This question had so much debate, so I want to hear from you in the comment section below as to whether you agree with what I'm about to give you, because I made some consultations. I asked a few individuals, and I really want to hear your input on this question and your reasoning as to why you think this is the answer as opposed to anything else. So here comes the question. Para 7 mother, 49 years old, is admitted in the gynecological ward with a history of vaginal bleeding and lower abdominal pain and amenorrhea. The os is closed. Take note, the os is closed. And her blood pressure is 100/70, pulse is 120. So she seems to be tachycardic and almost hypotensive. She expelled a few clots at home. She is currently not bleeding. She does not remember her last normal menstrual period. Gravindex is positive. So it means that for whatever case, this woman is pregnant, okay, or was pregnant at this point in time. She's coming in with vaginal bleeding, low abdominal pain, and amenorrhea, okay, 3 important things. And these vitals that are almost tipping her into hypotension. So what is the most likely diagnosis? What are the 3 differential diagnoses? What is the value of ultrasound in this patient? How will you generally manage this patient? So you may pause the video right now, think through this question critically, and actually understand. Now, here comes the answer. So, this woman here who was presented to you with low abdominal pain, amenorrhea, and she's not able actually to even remember her last normal menstrual period with vaginal bleeding, most likely that's a history that points you towards ectopic pregnancy. It may actually have been ruptured. And remember that the extent of the derangements in the vitals actually correlates with the extent of the blood loss and the extent of the rupture, because remember that it sometimes will be concealed hemorrhage as opposed to revealed hemorrhage, so which is why the blood pressure may not be as low as is. Okay, then why I didn't think that this was actually a spontaneous abortion is because if we look at the state of the cervix, okay, they've given us features of abortions also, passing clots, vaginal bleeding, I agree with that, and amenorrhea, I do agree with that. But if you look at the os that's closed, if you were thinking incomplete abortion, the os often in incomplete abortion tends to be open. If it's a threatened abortion, the os is closed, but you still will not get this history of passing clots in a complete abortion. or even in an incomplete abortion, like I already explained. So that's why it gave me a lot of debate as to this wouldn't be a complete abortion versus an ectopic pregnancy. And that's why I went and swayed with ectopic pregnancies. But I want to hear how you're thinking about it in the comment section below. So my differentials were a spontaneous abortion, a ruptured ovarian cyst. You may also have hydatidiform mole. Sometimes you may even have red degeneration of a fibroid. Then, of course, what is the value of ultrasound scan in this patient? So you want to assess the location of the pregnancy, you want to assess the fetal viability, and of course the contents of the uterus. How will you manage this patient? Remember your ABCs. Do not write ABCs in the exam, for Christ's sake. Ensure that the airway is patent, the patient is breathing, administer oxygen via face mask or nasal prongs, whatever you have. Gain access with 2 large bore cannulae. Draw bloods for investigations. That's your full blood count, your cross match. Okay. In addition to this, catheterize the patient, monitor your input-output chart, start IV fluids, of course, do a cross-match and transfuse this person with blood. Then, of course, sign consent and take this person for emergency laparotomy, depending on the extent. Because remember, this is an ectopic pregnancy that has ruptured. Okay, so emergency laparotomy, that's what I will be going for. If you enjoyed this video, please drop a like on the video. Geez, I don't know what's happening to my English. Please drop a like on the video, drop a comment, hit the subscribe button if you haven't, hit the bell notification icon to be receiving notifications of such videos every time I post. We are so close to almost reaching half our target before June. Remember, we should get to 2,000 subscribers before June. If you do that, you will make my year. And then, of course, subscribe if you haven't. Tell a friend who's writing exams that we are covering the episodes of exam week this week. If you haven't yet subscribed, please subscribe. To Zambia and beyond, my name is Dr. Moses Kazevu.